Well, it's an absolute delight to be here, and we've got a lot to cover. I'm a bit of a walker, so I probably won't be back behind here too much. One of the things that may come to your mind, it would come to my mind if I was sitting there, why is a guy from Nevada, where medical aid in dying is not legal, here talking to us about this law? Well, for those of you that don't know the Reno Tahoe area very well, we're about 8 miles from the border of California, and a very large percentage of our patients are actually California residents. I do have a California license, believe it or not, and as Aaron mentioned, grew up here and studied, did my residency training at UCLA. But the way I got involved in this sort of was a way to put my economics hat on, as well as my medical practitioner hat. The way I got involved in trying to learn more about this is actually when we had patients at our hospital, at our medical school in Reno, who were contemplating or were offered assistance with medical aid in dying. And really that piqued my interest and got me very involved in trying to learn as much as I could about the issue. And it comes up over and over again, and we'll go over in some detail a lot of the reasons why I think, regardless of your specialty or whether or not you think you're going to come across this, why you really need to be educated as best you can in all the aspects of what medical aid in dying or physician-assisted suicide entails. One little housekeeping item, your paperwork says 2 hours. I'm not going to keep you here till 2 o'clock. We'll try to wrap up about 1 o'clock. So the CME will do about an hour's worth today. So with that in mind, the purpose today is to help physicians, providers, and others try to ensure as best we can the autonomy of our patients who come to us requesting aid in dying medications under the California End-of-Life Option Care Act. So how did this come about and where does it come from? I think this is probably something that in this day and age of people wanting to live forever and the youthful movement always being there, be young, be healthy, we tend to forget that nobody gets out of this alive. So I always like this definition. Life is a noun. It's a sexually transmitted disease which always ends in death. There is currently no known cure. Now, I'm sure you've all had patients and families that need or have a little trouble understanding that and need a little bit of a reminder. But with that in mind, we have a finite time here, and all of us come to that realization sometimes quickly, sometimes slowly, sometimes never. And that certainly can affect the dynamics of not only their medical care, but I think just as importantly, their dignity and the input from their family and the expectations of family, friends, and the patient. They all play such an important role when we analyze this. So what are our objectives today? We're going to try to understand and dissect a little bit the eligibility criteria under California's End-of-Life Option Act. And then talk a little bit about what we'll call a patient-centered dialogue strategy in clinical settings in order to try to assess the criterion in each individual case and look at the ways we can ensure that patients are protected, that not only their dignity is respected, but their autonomy is verified. And that's not always as easy as it sounds. So we're going to look at it, we'll use what we'll call a patient-centered approach. And some of you who have worked with what we'll call medical homes in the past, I think the concept of that is valid here. We're a group of people who dedicate ourselves to the care of others and the good of our patients. And sometimes we have to be very, very, very careful that we don't let our own unconscious biases, our own past experiences, and our own expectations, which may be valid or invalid, inadvertently affect the patient in an adverse way when it comes to that decision making. So we try to be obviously as objective as we can. So how can we picture autonomy? What does that really mean? We hear that term a lot, throwing it out there. Oh, patient autonomy is critical. Well, what does it really mean? So let's mean Otto. Otto, the guy who wants autonomy, right? Isn't that cute? So when you meet Otto, Otto shows up in your office or it's in the hospital and Otto's interested in obtaining some medical aid in dying medications. What are the ethics surrounding that request? Does morality play a role here? Where does that come in, or should it come in? What about patient rights? How do we define patient rights in a situation where we're talking about doing something that may be contrary to how most of us were trained, especially those of us in the older generation of physicians? And what about our rights? What about our rights as physicians, as providers, as caregivers? Where does that come into all of this? It can be a very difficult situation, which often ends up with the final exclamation of, why me? Why did I get this case? Why do I have to deal with it? You know, I think this slide, if we start with this, it's an easier way to segue into really understanding what our role is as a physician, as a caregiver for other people. And I always love this. A physician once said, the best medicine for humans is love. And someone asked, what if it doesn't work? Then increase the dose. So, qualified. Otto's requesting aid in dying medications. Is he qualified to request that? Another way to look at it is you could use the word, is he eligible? Does he meet the criterion to qualify for the aid in dying drugs? What are the basic criteria? So here, age over 18, California resident, terminal diagnosis. What's the terminal diagnosis rule? Anybody know off the top of their head? What does that mean? One of the med students or residents should know. What constitutes a terminal diagnosis that would qualify for medical aid in dying? 6 months or less to live. So, terminal diagnosis where his physician believes he has 6 months or less to live. How accurate do you think we are on that usually? Exactly. So if you go into the literature, you'll find various studies that show our average error in predicting life expectancy when someone is first given a terminal diagnosis is anywhere from 30 to as much as 70% off. Often short, sometimes long. I think those of us that have been around for a while have all had patients that we put on hospice and then gladly taken off of hospice, because hospice has the 6 months or less rule, right? I see patients in the grocery store all the time. 19 months later, hey doc, I'm still around. Say good for you, I give them a big hug. So that's a real tough thing. Now notice too, and I'm going to come back to this, but I just want to plant this seed in your head. The terminal diagnosis of 6 months or less to live in the law does not say with treatment. I think that's important. It does not say with treatment, which means it could be without treatment. Without treatment. So think about those patients you have that are not terminal, but would be if they stopped any medical or specific medical interventions. An important thing. Informed consent. That's another critically important criteria here. And if you're a surgeon, informed consent you could probably do in your sleep, right? We see those notes. There's a paragraph that says, you might bleed, you might get an infection, you might die, somebody might throw you off the bridge. These are all known complications of my procedure. Sign here. Informed consent goes way beyond that. We need to make sure the patient has the capability of understanding the information at a level where they can not only assimilate that information, but be able to make a reasonable and rational choice based on that information. And that gets into a whole bunch, as you might guess, a whole bunch of other little very important but very subtle nuances that we have to analyze when we're looking at whether or not the patient is even capable or has capacity for informed consent. And that brings us to mental capacity. So when we talk about a patient having capacity, is it an all or nothing? What do you students think? They have capacity, they don't? Is that it? Well, you could probably guess by the way I'm asking. Capacity, having the mental capacity for decision making, can be all or nothing. It can also be compartmentalized at some point. It can have a lot to do with what area of the brain or the system you're talking about. If you have anybody that you know that's worked with public guardians, you'll know that there's a lot of people out there that might have a guardian for financial affairs, but they're still allowed to make their own decisions for medical decision-making issues. And even within medical decision-making issues, we were talking about this just at lunchtime, somebody may have the capacity to understand simple, non-complex medical decision-making, but something that's very, very complicated and high-end, they may not have the capacity to understand or be expected to make a reasonable decision. So mental health's another one. So how's mental health different from capacity? Do you have a mental illness? Let's start with that. That's the simplest. So depression, a psychotic disorder, a depression that's reached a level of psychosis. So since we have my dear friend who's a psychiatrist here, my surgeon father, because you know how surgeons think, right? Internists, we always pick on surgeons. He used to tell me that psychiatry was straightforward. The difference between a neurotic and a psychotic. He said neurotics build castles in the air, psychotics move in. So that was my earliest understanding. Now they do it on the internet, that's right. That's right. So another thing to keep in mind with mental health, when we get into these laws, is what is the requirement for referral, and is it actually happening? Is it actually happening? So think about that, and we'll come back to that a little bit. And then voluntariness. Is this a voluntary decision? That can be a lot trickier than you might think. I had a patient recently who had an advanced lymphoma. He was responding to treatment, and he really needed a bone marrow transplant. He had a lot of money, and his family thought that maybe he shouldn't bother with all of this stuff. And he tried his darndest to convince everybody around him that he really didn't want any more aggressive treatment. And it was a little difficult at first to tease out, but it quickly became apparent that he was doing this or making this decision not to pursue an aggressive therapy out of loyalty, out of duty, out of not wanting to be a burden to his family. When isolated in a silo, it really wasn't what he wanted at all. But because his family wanted it, that's the way he was going to play. What do we call it? Team player. Take one for the team to a fault. To a fault. So how do we picture autonomy? We start to put this concept of autonomy together a little bit and think about how it comes together. Well, I really like this, this little photo here, this little clipping. There's a lot of different pieces that come together to determine whether or not you truly have autonomy. And if any one of those pieces is not in place, the whole thing falls apart. So it's not just that you have to have the blue little puzzle piece or the yellow one or the green one or the red one. You need to have all four, and they really need to come together as a whole in order for autonomy to be present. So they break apart, we got a different thing, but even one piece out can be a problem. So let's now talk about how we're going to unpack this and break down the End-of-Life Option Act in this way. So the first thing we're going to talk about is the terminology. And what are the actual definitions with this act? And what do they mean and what do they require of us? The second step is process. So what is the process of actually going through and assessing autonomy in any given patient? And finally, what action do we take after we've assessed autonomy in a given patient? What action do we take? What competencies do we need in order to effectively put this into our practice pattern and make it consistent and as objective as we possibly can? So, start with the terminology. Aid in dying drug. What is that? It means a medication that's determined and prescribed by a physician for a qualified individual, which the qualified individual may choose to self-administer to bring about his or her death due to a terminal disease. So there's your definition of an aid in dying drug. How about the qualified individual? Again, you can use the term eligible if you like. A qualified individual for this act is an adult, so age over 18, who has the capacity, we've talked a little bit about that already, we'll get into more detail, to make medical decisions, is a resident of the state of California, and has satisfied the requirements of this part in order to obtain a prescription for that aid in dying drug to end his or her own life. Self-administer. That's an important differentiation. Self-administer means a qualified individual's affirmative, conscious, and physical act of administering and ingesting the aid in dying drug to bring about his or her own death. If you are assisted, if someone gives you the drug, you don't take it yourself. If someone administers the drug to you, what do we have then? That's called euthanasia. That's called euthanasia. So this is a very distinct, as far as these laws coming into practice starting 20 years ago with Oregon in 1996, very distinct separation. Yet I think you will see, and you are seeing, read the news and you look at the evolution of this practice, a lot of blurring here in what's self-administration versus what's voluntary euthanasia. Some of you may have seen the CNN article a week or two ago. Anybody see that? About the gentleman, I think he was in Southern California, who participated in this end-of-life act. Anybody see that? So, he was unable to swallow all those capsules. So a volunteer opened each and every one of those capsules and put the contents of the capsule into a little slurry, sort of a speech therapy version of Thicket, made it for him, and then helped him to drink it. So is that still self-administered medical aid in dying, or are we now getting to the point of euthanasia? It's an open-ended question. I'm not going to answer that for you, but we are seeing lots and lots of things shift in that direction, So, this is not a HIPAA violation. I'll start with that since we're all physicians. This is the photo of that gentleman's actual prescription from the CNN article. So this was, you can bring this photo up online. Those of you who may not be aware, this is the typical, it's not always the same drug that's used. This is the typical prescription. Usually it's between 90 and 100 capsules that are prescribed of seconal, secobarbital. And when I give you the data and the information, because the law in California is relatively new, a lot of what I'm going to tell you about comes from the full 20 years of experience in Oregon. So over 90% of the cases of medical aid in dying of assisted suicide in Oregon used this medication, and they're trying to come up with some different ones. And you may ask yourself too, how easy it is to swallow 90 or 100 capsules. I don't know if I could do that. And with that in mind, and we'll get into some detail on this, you have to, from a medical perspective, be aware that patients are prone to regurgitate this, to vomit it back up. And there have been numerous recorded cases of that, because that's a lot of capsules to swallow. Think how angry your nurses get when they have 10 pills to pass at once, let alone 100. So something to think about. So the lethal dose is thought to be between 9 and 10 grams. Again, these are 100 milligram capsules, and that's why the prescription is the way it is. So terminal disease. Terminal disease means an incurable and irreversible disease that's been medically confirmed and will, within reasonable medical judgment, result in death within 6 months. Now, I commented a few minutes ago when we talk about informed consent. This is a place where I think we fall down on the job a little bit. Back to our typical error, should we say, in life expectancy when someone first receives a terminal diagnosis. It's highly variable. With my medical students and residents on the wards in our hospital, I really emphasize every time I have a new team, we're pretty good at diagnosis, and we're really good in knowing, and our pulmonary critical care colleague here I'm sure will attest to this, really good at knowing when you're going to go in the next few hours or a day or two. We're pretty good at the end of the end. So we're good at giving you that label. You've got metastatic pancreatic cancer. We're really good at saying, you know, he's got a Kussmaul respiration pattern. He's not long for this world. He's going to go in a little while. That's it. In the middle, as physicians, and again, this is backed up over and over again in the medical literature, we're very, very poor at predicting how long someone is going to go. So to say with some certainty that it's 6 months or less can be very problematic if we're overly concrete with that decision. I think we owe it to our patients and our families to have, as part of our conversation, the fact that we're very bad at predicting how long you might have with any given illness. And again, once you get near the end, okay, we can usually tell. You're within hours to a few days of death. But this is a very, very tough thing. I think of a patient I use the example of metastatic pancreatic cancer. I had a patient who went on hospice with metastatic pancreatic cancer. And she lived way, way up in the mountains, north of Tahoe, up towards Mount Lassen and Lake Almanor, middle of nowhere. And we had stented her, put in a biliary stent palliatively, and she was doing okay, and she went on hospice. And I was very angry because hospice never called me to tell me that she passed away. And every month or two, I'd call them to say, why haven't you kept me informed? And they said, because she's not dead yet. And this went on for 19 months. So here's somebody, I'm pinned to the wall. I would have said probably 2 to 4 months, maybe 5 or 6 if she's really fortunate. And she went, make my example, she went 19 months, 18 and a half of them were really good. And the last 2 weeks, she needed some interventions with our palliative hospice folks, making sure they amped up the medications to keep her comfortable. So something to keep in mind, when someone's interested in medical aid in dying, please, please do your due diligence and really research not the average life expectancy for that diagnosis. Look at the bell-shaped curve. Look at the standard deviation. If it's 99% are gone in 2 months, fine. But we don't find that too often. I think of Brittany Maynard up in Oregon with her glio. And we all know glios are just awful, awful diseases. So does anybody know what percentage of glios are dead at a year? Anybody have an idea? 70%. It's not 90. It's not 95. And with the radiation therapy available, we actually don't really know who's going to respond very well till we do it. So there's a part of a conversation you may want to have. Somebody comes in with a glio. They say, well, my understanding is I'm certainly going to be dead in a year. Well, not necessarily. 70%. Again, we're not looking at median survival. We need to look at that bell-shaped curve and see what the spread looks like, right? What are the standard deviations on that survival? I think we owe it to our patients to make sure that that's part of their informed consent, isn't it? That's part of autonomy, having full knowledge, not just some flippant answer, wrap yourself in a flag and put yourself out to sea, you're done. That really doesn't do anybody any good. So that's the terminology side. The other thing I guess I should have mentioned, I'm sorry, I want to go back to this. I hit on it briefly, but I want to go into it a little bit. So the 6 months or less to live there's no caveat as to whether or not that's with or without treatment. So technically, by the letter of the law, whether it's in Oregon or California, you could forego treatment, and if foregoing that treatment would make your probable life expectancy 6 months or less, you would qualify for the Aid in Dying Act. You would qualify for EOLA. Technically, if you were a diabetic and wanted to stop your insulin, I couldn't say you're not terminal. You're terminal. And we can all think of multiple examples like that. So as far as the capture of the law, the reason I bring this up is solely so you'll understand that the law is a lot broader in its capture of potential patients than you might think. So if someone came to you and said, I'm interested in this, and you said, well, you're well controlled on your Entresto and your Lasix and your Aldactone, your ejection fraction's hanging in there. Technically, if they stopped all those drugs, how long would they last? That's in the law. So it's an act of omission, we'll call it. Because it doesn't say with treatment, it means that if you stopped your treatment and it results in 6 months or shorter life expectancy, you would qualify. Process, assessing autonomy. So once again, we have all these pieces of the puzzle, and if any one of those pieces falls out, we've got a problem with regard to autonomy. So what is qualified or eligible? Again, we talked about the basic criteria, 18 years old, resident of the state of California, right? Informed consent. Now that informed consent thing gets a little more complicated. As I mentioned, I think we all have an obligation to dig as deeply as we can on what are the variables involved with any given diagnosis and the different treatments that can be offered. I think in informed consent, we also need to be able to discuss the capabilities of hospice and palliative care in concert with or in contrast to medical aid in dying. Many people who seek medical aid in dying are enrolled in hospice, are involved with palliative care, but they don't have to go together. They can be separate or they can go together. And that's something I think we need to look at very carefully. So many patients in frustration and fear think that it's an all or nothing. And I think that's where we can really help them when we talk about, and I think we have an obligation to talk about all of the end-of-life treatment options that are available, assuming they don't want to continue to pursue aggressive therapy. Mental capacity, we talked a little bit about. Again, this is something where medical decision-making has to be assessed separately from other issues like financial ability to keep a checkbook and overall. Now, mental health, this is a tough one for me. There's supposedly a safeguard, and all the laws for medical aid in dying have this safeguard. And the reason I say supposedly is the Oregon data is very disappointing, I believe. So it says if you suspect someone of having a mental illness or depression as an example, that may disqualify them from having a reasonable capacity and informed consent to make these decisions, you're obligated to refer them for a psychological assessment prior to proceeding. So in 20 years of data, 1996 through 2017, I guess that's 22 years of data, what percentage of people do you think were referred for mental health evaluation who had requested the drugs? Anybody have an idea? 3.8%. 3.8%. That's it. I think that's a problem. So it's written in the law, but obviously something's breaking down here. Being depressed, by the way, and I hesitate to say this in front of my psychiatry friend, but from a simple internist perspective, if you told me I had a terminal diagnosis, I can tell you I'd be depressed. Now, it may be an appropriate grief reaction, a reactive depression per se, But I know that I wouldn't feel normal about it. And I find it very interesting that 3.8%, less than 4% of people were referred for mental health assessment. Guess what number of patients were denied the pills, the medical aid in dying pills, because of mental health issues or psychiatric problems in 20 years in Oregon? 0. Once again, as physicians, if it's written into the law, there's some breakdown here, and California's law is so new and young, don't have any data for you from California, not on that at least. But that's something we need to pay very close attention to. And part of the problem, I think, may be, and we get into this in the process, is the safeguard of the 2 physician approval for the medications. And we'll get into some of the positives and negatives of that in just a moment. So, voluntariness. I gave you the example of my patient whose family pretty much wanted him to kick off, get their hands on the money, and he was willing to forego a life-saving treatment because of that. I had another patient, and he can argue whether this is voluntary or not, similar scenario. Patient was a schizophrenic who wasn't completely in remission. He wasn't as acute as he'd been a few weeks before, but he wasn't in remission. And he was interested, he had other disease processes, but he was interested and frustrated with medical care and interested in the medical aid in dying medications. There's another tough example. What is that? Should we consider that voluntary? Well, it gets back up above to the third bullet. Does a patient like that have capacity at that time to really make that decision? So it's our job to confirm that this basic criteria is met. And I think more than anything, the informed consent part is really one of the big keys that we need to spend more time on. We really need to make an effort to make sure that all of these other aspects that maybe we don't think about deeply enough are looked into in some detail, especially with regard to life expectancy and alternative therapies. 18 years old, California resident, terminal disease with prognosis of less than 6 months to live. According to whom? Who does it require? Who has to say it's 6 months or less? The attending physician. And as we'll see in the process further out, you have to get a second physician to agree with that. So one thing to keep in mind, and this is again something that we have to be very careful of, is that physicians tend to refer to like-minded physicians. And we got to make sure that that's not a pathway that takes our objectivity away when it comes to assessing true life expectancy, especially when we look at the bell-shaped curve. So must have the ability mentally and physically to take the drug independently. I'm not sure that case in CNN the other week, which was here in California, met that criteria. And that was national and international news. So here's an example. A 20-year-old college student in Los Angeles has diabetes. He was told that an amputation will be necessary. Horrified, he told his mother he prefers to take aid in dying drugs. And then he falls into a diabetic coma. Can the mother request that her son be given aid in dying drugs? What do you guys think? Yes? No? I keep picking on you. No. No. And why not? Well, at a very simple level, a surrogate cannot request medical aid in dying medications for someone else. So that stops it right there. What else comes to mind?
He's not fully informed. He has no idea what his life will be like after an amputation. He doesn't know about prosthesis, physical therapy, retraining, etc.
I think that's an excellent point. He does not know what that really means and what kind of life and positivity can still be there moving forward. You know, when we talk about unconscious bias, there was a political pundit who passed away not too long ago named Charles Krauthammer. I don't know if you remember him. A lot of people don't know he's a physician. He started out to go into neurosurgery, and he had a diving accident in medical school and became a quad. If you ever saw him on TV, you'd never know he was quadriplegic because they propped him up so perfectly in his suit. He just looked like he had really good posture. So Krauthammer, he wrote a piece years ago, and he's a psychiatrist, and he said, a great example of unconscious bias on valuing life, especially with the younger generation, he said would be with someone like me. They'd be in your ICU, quadriplegic, here for some other reason. You know, they've got a pneumonia, they've got whatever it is. And they're talking about end of life and code status and all that. And the young residents come in and they look at him and they say, I wouldn't want to live like that. And they start talking to the family about code status and on down the road. And Krauthammer's point was, I love my life. I have a very fulfilling, happy life as a quad. And he wasn't faulting the residents or the young doctors. He was saying, don't project your assumed value system on me. Back to not assuming what someone would want or not want based on what they look like in the bed. You see a 90-year-old laying in the bed with a bed sore, and what's the first thing that comes to your mind? I wouldn't want to live like that. I wouldn't want my mom or my grandmother to live like that. And maybe they wouldn't, but maybe they would. We've got to try to be, again, as objective as we possibly can. So an elderly is in her last months battling ALS. She has already obtained the drugs, but then loses her ability to control her arms and legs. Can a friend administer the drug to her? What do you think? Legally, no. I would argue this is already happening from the example of the case we gave. So I try to break up the slides a little bit with, a lot of it depends on what resources you have available, right? So this is from the Northwest Territories in Australia. I just love this slide. Notice they have a Lions Club. You know, they have enough money for eyeglasses. Maybe they should build a hospital. What do you think? I tell you, people slow down when they go by that sign, though. So the real take home on this part is the process needs to be a true dialogue, a conversation. It's not check the box. It's not pull up a chair, sit down, over 18. Oh, I don't know. Yes. California resident, yes. You seem okay. Capacity. What do you have? Lung cancer, 6 months or less. We've got to pause long enough to get to know that patient and get to know what's really ticking behind that. How will the drug affect the patient? You want to swallow 100 capsules of Seconal? How's it going to affect you? You want to regurgitate it? What are, again, the realistic alternatives between hospice, palliative care, and pain control? What if you wanted to change your mind? A lot of patients don't know they can change their mind. And the other part, what about notifying next of kin? Will somebody be present? What percentage of aid in dying deaths have a physician present? Anybody know? Between 15 and 18%. 15 to 18%, which means most of these are not witnessed by a physician. More than half are not witnessed by any healthcare provider. So something to keep in mind. Decision-making capacity. We talked about this, the ability to understand the nature and consequences of their decision. The ability to understand the benefits, risks, alternatives. Told you it reads like a surgery consent, doesn't it? And the ability to communicate. That's the key thing. Informed decision. Informed decision to healthcare providers. So here's the way we can make it a dialogue. Take all that gobbledygook. Are you worried about this illness making you more dependent on your family or your friends? Is that your big concern? We need to tease that out. Are you having difficulty thinking straight? Are you getting confused? Let's talk more about that. Functional capacity. Are you losing your independence? Are you horrified and embarrassed that you need caretakers to do basic things for you? These need to be talked about directly rather than, my life's not worth living, I know I'm terminal, give me the pills. So this would have been my father if my mother was bedridden. I guarantee it, that generation, he would have wheeled her right out to the kitchen to make him breakfast. I'm sure many of us have a family member or two like that. I figure you should have your breakfast in bed on your birthday. Can you reach the stove okay? I just love that. So the focus has to be on what is the level of independence the patient has in participating in that decision-making capacity to the fullest extent possible. How does their cognitive ability weigh into this? And one of the things we need to focus on is dealing with these other, we'll call it other ways of suffering. And we're going to talk briefly about why I say other ways of suffering. There's a lot more than just physical suffering, right? There's emotional suffering. There's all kinds, spiritual suffering, all kinds of suffering. And we need to talk about with our patients, what is it that they're really worried about? Because, it's not always pain. When you hear people who want to move fast on aid and dying, it's hurry up, cut the waiting period, cut this, because our patients are in pain and they're all in pain and we beat the pain drum over and over. In reality, pain, and I'm going to show you a statistic, is not very high on the list for most patients who request aid and dying drugs. It's not high on the list at all. It's more social and mental health issues. Again, I said we're required to refer a patient to a mental health specialist if we suspect depression or other issues which may interfere with their ability to make an informed decision for medical aid in dying. So number one, we don't know how long you're going to live. Number two, you're depressed because you just got a terminal diagnosis, and yet only less than 4% of people are being referred. We need to do better, and that takes education like this. It takes education, and it takes intervention. So no aid in dying drugs shall be prescribed until the mental health specialist has determined they have the capacity. Well, as I mentioned, in the Oregon data, it's never been withheld. It's never been withheld. In medicine, we never say always, we never say never. This one's a big fat zero. So mental health problems, whether it's depression, hopelessness, just a desire for a hastened death. There's a gentleman who had a glioblastoma, just like Brittany Maynard. And he thought about getting the aid and dying meds, and he didn't. And about month 3, month 4, he was really down in the dumps. And he told me that if he had had those medications in his nightstand on a dark and dreary night, he would have taken them. He went almost 4 good years. Again, 30% of glios go beyond a year. 10% go 5 years. He was almost the 10%. He had a rough last couple days or week, in which case hospice needed to do their thing, and they did it well, and he was comfortable. But that's another example of, if you're down in the dumps and that medication's available, we have to be very, very careful. It's like having a loaded gun in the drawer. Who wouldn't be down in the dumps on a dark and stormy night knowing they just received a terminal diagnosis? And the older generation tends to be more flippant along those lines. They get the bad news. How often do we hear, well, to heck with it? Just, it's a version of a loaded gun. Depression and hopelessness are the strongest predictors. Other factors, loss of autonomy, burden on others, physical symptoms, and then, of course, existential. So here's a slide I wanted to spend a moment on. This is 20 years of Oregon data. This is why patients requested the aid in dying drugs in Oregon. Notice that inadequate pain control, or even a concern about pain, even a concern about future pain, was only 25% of the people. Only 25%. So that drum of it's all about ending pain just doesn't hold water, especially with how far we've come with palliative care and hospice. Now, what should jump out at you and where we need to work harder, I'll flip the tables on you, look at the top. Losing autonomy. less able to engage in activities making life enjoyable, and then loss of dignity, however broad that definition may be. We need to be having more conversations about those issues in people that have terminal diagnoses. And I think we're failing our patients and not addressing those social needs. So that's actually, I think, the most critically important segue there. So how in control do they feel? What's still possible? What are their coping mechanisms? And I'm going to move ahead a little bit more quickly now, but once again, the focus is family. Family care, autonomy and control. We need to involve the patient and the family as much as we can. We need to provide something that's hopeful, that their symptoms, both psychological and spiritual as well as physical, are going to be addressed. And that any psychological distress, we will refer them and we will get them treated. So we've talked about this in some detail before, but the voluntariness, we have to be very, very wary of a secondary agenda from friends and family members. Very wary. And this does come up in most of the country, in the 7 states where medical aid and dying. One person cannot be a related family member or involved with the patient in some financial or other way, one of the witnesses. One doesn't mean somebody else can't. So the other thing I want to go on before we close here, because I'm running out of time a little bit, is once again the burden to others. That's one of the biggest. So loss of independence and burden to others. These are important social issues, but it's not physical pain and suffering why most people will come to you requesting these drugs. And I think that should take us to a whole different level of conversation when we address why someone wants these drugs to end their life right away. So, is there an indication of autonomy? Or is this reaching out really a sign of distress and suffering? You know, a lot of people have a lot of guilt about the life they've lived. And they figure there's no hope for them in the great beyond. You know, on the spiritual side, they're worrying about, was I really a worthy, good person? Did my life have meaning? Did I live a decent life? And for those of you that don't remember those songs, I love that. The fact there's a highway to hell and only a stairway to heaven says a lot about anticipated traffic patterns, right? So the timeline, I'm going to go through this quickly. Attending physician meeting 1, do they get a referral? Then there's supposed to be a consulting physician meeting, once again assessed for mental health referral, and finally the second meeting with the physician. And the attending submits the patient request and physician forms, and then the follow-up form. And in that process, it's 2 oral requests, 15 days apart, and 1 written request, and it must be done without anyone else present. We have to make sure that that's followed, and I'm not sure that it always is. Now, as far as a second consulting physician who confirms the diagnosis, the prognosis, and the capacity, we have the same issues with that as well. So, we're so used to ordering so many tests as physicians. One of the things we have to be careful of is that we don't look at the written record of the first physician and say, oh, he's done everything already. We don't need to do any more. So this was my HMO slide from a long time ago. Offhand, I'd say you're suffering from an arrow through your head, but just to play it safe, I'm ordering a bunch of tests. So with that in mind, after the second oral request and the written request, the patient has the opportunity to withdraw it. If they don't, that's the point they can get the aid and dying drug. So typically what we've found is once the patient has the aid and dying drug, about 60% take it. What happens to the other 40% of the prescriptions? And that's something we need to look at very carefully. They carry over into the next year. So finally, if we are sure that the patient's autonomy, all those pieces of that puzzle, from informed consent to mental capacity to a lack of mental illness to the fact it's truly voluntary are all present. We need to continue that dialogue to find out if there are things that we can address, especially in the social realms of burden to family, the guilt from that, loss of dignity, loss of independence. And finally, that autonomy and our ability to recognize that patient's dignity by digging beyond the simple pain, and I'm worried about pain when I die. Again, that's a small percentage. Knowing that our ability to diagnose terminal illness is good, but our ability to predict life expectancy stinks. All of those things need to come in that dialogue, that patient-centered and directed dialogue. And if that process is there, we finally need to ensure that that true consent doesn't involve a secondary or hidden agenda from somebody else. So with that in mind, thank you very much for your attention. I appreciate you coming, and I'll hang around a little bit if anybody has any questions.
One of the questions that I would ask is, are there any financial considerations? And I'll answer it, okay? So what does it cost to keep someone alive who has stage 4 lung cancer? And you know the answer, it costs a lot, okay? What does it cost to give them the Seconal? Doesn't cost much, does it? Okay?
They increased the price to several $1,000s.
Yeah, they increased the price when it had a demand all of a sudden. In the 60s it was cheap, now it's expensive.
So I was sentenced to be chairman of medicine at St. Joseph Hospital for 2 years. And that gave me the ability to order stools. Not stools for occult blood.
That's what I was thinking, right, guy?
Yeah, right. Stools, this high. And that meant that the physician should sit and have a conversation with the patient at eye level. Now, there are health plans, I will not name it, where a complete, quote, complete evaluation of a new patient is accomplished in 15 minutes. 15 minutes. Solomon, you're there, right? Solomon and I are both palliative care physicians. How good an evaluation of the patient, including things like their spirituality, how good a job can we do in 15 minutes?
Yeah, obviously not, I wouldn't say a semi-good job, I'd say it's no job at all.
That's
Which,
exactly right.
very interesting, you're probably familiar with this study, many of you may be, doesn't answer the, I should rephrase that, it doesn't solve the problem, but it is interesting. I'm sure you both remember the study where they had the intervention group, the doctor went into the hospital room and sat down, and the control group, the doctor stayed standing, and they were in there, I want to say it was 2 minutes. I'm going to get the numbers wrong, but you'll get the idea. So it was 2 minutes. The patients perceived the guy that sat down was there for a median of like 7 or 8 minutes, and the guy that was standing was there for a minute. Something, I mean, some incredible difference. But what you said, I want to go back to what you said about the cost, and that's very important. One of the things that really piqued my interest in this issue and how it's evolved, being in Reno and right by the border, I had 2 cases in the hospital about a month apart. This is late 2016. Both needed BMTs, life-saving treatments. One was across the border going to California, one was in Oregon. And not quite a month apart, both of the insurance medical directors said, we're not going to cover the, the transfer and all that, but by the way, just threw it out there, by the way, have you talked to them about medical aid and dying, assisted suicide? They actually said assisted suicide, they didn't say medical aid and dying. And I was so stunned, I didn't know what to say. All I could come up with was, it's not legal here. It's like, well, they'll be back in their home state soon. And, it's like, just throw it out there. And, the old thing, it's cheaper to give you a bunch of pills and kill you than it is to treat you. And let's be direct about it. From a libertarian side of things, these laws are very appealing. I mean, they're appealing to me for that reason, in that I want freedom of choice. I want every choice I can have, right? It broadens choice. Well, those 2 cases turned my head around real fast, and I thought, in a society where insurance companies have so much power, unfortunately, because it's the cheapest thing, it actually limits choice. So it's going to cut, I see choices being limited over the long haul if that becomes the cheapest option. And you reminded me of something, Derek Humphrey, anybody familiar with him?
Yes.
Derek Humphrey was the founder of the Hemlock Society way back when, and that kind of morphed into the Compassion and Choices group directly. But he said in his 1998 book, and this just really struck me, and I looked this up after my two cases, he said in the final analysis, economics, not the quest for broadened individual liberties or increased autonomy, will drive assisted suicide to the plateau of acceptable practice. Now, agree or disagree, I mean, that could be fine. I mean, it depends who you are, but we are naive and ignorant if we don't look at the fact that economics is going to drive this. That should be out on the table as a fact of life. And you may disagree, you may agree that that's okay. We have limited healthcare resources, right? So you could make the argument. But I think we do a disservice when we pretend that that's not a reality, that economics is not one of the driving forces of this. So I agree with you that. And any conversation you're going to have about this, I think the more we get out open on the table, the more transparent we are, the better a conversation we can have. Yeah, but you were going to ask.
Thank you for an excellent and very in-depth discussion on the subject. I'd like to come back to one point that you made and expand on it a bit, and that is understanding the patient, having a conversation with the patient. I give the same talk that you're giving to community hospitals, and because we have trouble walking in the shoes of someone who's terminally ill, because none of us are,
right,
except eventually, I asked the men in the group if they will listen to talk to one of the ladies near them and describe what that lady will go through or what she went through in the 24 hours of her delivery of her first baby. And then to ask the lady how accurate it turns out to be. I think we can't put ourselves in the shoe of the terminally ill, and therefore we do have to listen to them.
Yes.
And the listening has to be, as Steve Covey says, seek first to understand, then to be understood.
Yes.
Because we come in, as you point out, with our own thoughts about what a reasonable goal would be. We want palliative care, we want hospice, and that's proven by Oregon that those are very beneficial. So we have trouble understanding the person. We need to listen to them more and see. And if you think a little bit about it, you have to keep reminding yourself that life is going to stop sometime. We may not be able to predict it. They know that their life is going to stop sometime in the reasonable future. And that changes your whole perspective. Your goals for your life change immediately when that happens. And it's because of that, we're not in their shoes that we have trouble accepting this, and we want to fight it. And indeed, nobody wants to. And you didn't use the word suicide, which I greatly appreciate, because the similarity between assisted dying and assisted suicide is that the time is cut short. But for the terminally ill patient, it's cut short a few weeks or a few months, and with the suicidal patient, it's decades of life. Also, the tragedy in the suicide is much different than the patient who takes the pills. And the pills, by the way, it's inhumane to get them to take all those capsules. You have to separate them, you have to put them in applesauce or something like that, and it has to be taken in 2-3 minutes, because you'll start falling asleep before you complete the dose.
No, did you mention Stephen Covey, is that who you said? He stole that from St. Francis, by the way. St. Francis of Assisi said that 1,000 years ago.
It's in his book.
No, but I know. No, I read it, and I remember thinking he stole that from St. Francis. But anyway, that being said, it's interesting, too, on the number of pills. I looked a little deeper into the data on the people that did vomit or regurgitate and what happened to them, and sort of little darker side medical humor, I thought. It said very cryptically, no one attempted this a second time. I thought that was interesting. So, yes, sir.
Yeah, parenthetically, I also was an economics major.
Oh, I love it.
One of my concerns is that I think a lot of this movement is driven by poor quality or inadequate access to high-quality palliative care.
You're absolutely right. Yes.
And
100
I
times
think
yes.
This, to me, this is not the right solution. The right solution is to get patients high-quality palliative care. And to not provide them with the appropriate care, I think is unethical.
Yeah. Well, you know, I think you're right on the mark, because one of the things I always keep coming back to, and one of the things why I tried to emphasize it, is not knowing how long someone's going to go before the end of the end. And then can we ensure they have adequate palliative care and hospice interventions when they get to the active phase of dying, you know, making sure that we truly, and address those other issues which palliative care would address as well. Those burden to family, those meaning in life, the spirituality things that we've all talked about. Those are right there. You saw that. Pain, 20%. Burden to family, loss of enjoyment, 90%. Yes.
You didn't mention it, but doesn't the law have something in it about unendurable pain?
Which, they all say, it says in their preambles, to eliminate unending and enduring pain.
Is that one of the requirements?
No, but it's in the preamble. You know, in order to address people who at end of life have pain and suffering, and that's how we do it. But anyway.
Okay. Thank you all for coming. Anyone who wants to stick around for a small group discussion is welcome to, but I want to be mindful of folks' time. And let's thank Dr. Callister once again.